Good morning, and thank you for that introduction, Andrew. So he's already told you this about me, so I think we can probably skip this slide, except to say that I have no conflicts of interest with regard to this talk. I do also want to say that I want to thank the chief residents for inviting me here to give Department of Medicine grand rounds. So my talk is really aimed at the residents in the Department of Medicine, but I hope the faculty will also learn something today. So if you need to have learning objectives for the talk for CME, this is what they are. Basically today I'm going to talk broadly about the scope of medical genetics as it applies to medicine. I hope by the end of it you will learn what the 3 possible results of any genetic test are and why variant interpretation is clinically important today. To learn about the difference between genetics and genomics and to be able to define precision medicine and where it is going, and also to have at least a basic understanding of pedigree analysis and who in a family is at risk for a genetic condition. And probably most important from this talk, I hope that you take away from it when to think about genetics and how and who to refer to. So by way of introduction, genetics is the study of heredity and seeks to explain the basis of individual variation that we see as we look around the room today. Medical genetics is a branch of medicine which deals with genetically influenced biologic variation that is relevant to human health and disease. So really in the medical genetic space, we're talking about diseases that are genetically determined or influenced. And in the bottom of this slide, I have 3 examples. So the 2 children on the left have a childhood form of premature aging called Hutchinson-Gilford syndrome. The little girl in the middle has trisomy 21 or Down syndrome due to the addition of an extra chromosome number 21. And this little boy has oculocutaneous albinism, which is an autosomal recessive condition of pigmentation. I also do want to talk today about the Medical Genetics Clinic and the Division of Medical Genetics here at the University of Washington, which I consider to be a true jewel in the crown, that is the Department of Medicine. The Medical Genetics Clinic was actually founded here in 1959. So only a few years after the elucidation of the double helix structure of DNA by Watson, Crick, Franklin. And this is actually Arno Matulski, who founded the Division of Medical Genetics here in 1957, founded the clinic in 1959, and is still part of the division today. This historic photo from 1962 is actually clinic conference. And so there is Dr. Matulski with his trainees, and actually the patient attended the clinic conference also. So today, this is the group in clinical medical genetics that sees patients within our clinic. The clinic has grown to see over 2,500 patients per year. And cancer genetics is our largest area. Over half of the consultations we see are for cancer genetic indications. The fastest growing area is cardiac genetics. And importantly, we are the only medical system in the entire WWAMI region which has physicians who are board certified in clinical genetics. And 5 of our attending physicians have been chosen as top doctors in Seattle Magazine. So in this photo here, and again, Dr. Matulski is front and center and standing next to our current division head, Gail Jarvik. There are 4 internist geneticists in this photo. There are 3 attending neurogeneticists, and there are 4 clinical genetic counselors that comprise our group. In addition, we have 4 additional internist geneticists here, here in the Department of Medicine: Wiley Burke, Marshall Horowitz, Wendy Raskin, and our newest faculty member, Dr. Sirisak Chanprasert. So far that's 8 internist geneticists, and while I realize that may not sound like much if you're in the Department of Cardiology or the Department of Gastroenterology, I will tell you that that is the largest group of adult geneticists anywhere in the country. You might think that things are bigger in Texas, and there's a wonderful genetics program in Texas at Baylor, but they have half the number of adult geneticists that we have here and see fewer than half the number of patients that we see. So when I was a medical student, I remember a surgeon told me that diseases are caused by bad habits, bad luck, or bad genes. And I have remembered that to this day. So if I sort of recast that in this genetic environmental continuum here, you could say that people who engage in smoking, bad habits, or drinking can develop lung cancer or liver cirrhosis. People who have the bad luck to be in a motor vehicle accident or to be infected by tuberculosis or infectious diseases are again over here on the environmental end of the disease spectrum. Whereas over here is where I work, basically in genetically determined conditions. And of course there is overlap here in the middle with complex traits like ulcer disease and diabetes and heart disease, which have both genetic as well as environmental components. And I think many people outside of medical genetics think that medical genetics is synonymous with rare diseases and typically are present at birth or affect children. There are lots of obscure eponyms in medical genetics, things like Pallister-Hall syndrome or Rett syndrome, and most of these diseases are basically never seen by the vast majority of practicing physicians. I would say that that picture is really quite incorrect nowadays, and all you need to do is look at the statistics for the growth of the medical genetics clinic here. So again, if we go back to 1997, there were about 250 patients seen annually, and again, I came to the University of Washington here in 2009, and the total number of patients has increased year over year at a pretty remarkable rate. So clearly genetic diseases are not becoming more common, but basically our recognition and our evaluation of them has really been transformed. And again, you can see here that over half of our work is in cancer genetics. Neurogenetics is another large area. Cardiovascular genetics is increasing, but we are a comprehensive adult genetics clinic that sees patients for all indications. And this is partly driven by, again, increased recognition and the importance of medical genetics to medicine, but also because of changes in technology. And the only thing that I can really compare the technological advances in genetics to is the changes in cell phone technology. And this is a photo from the 1980s of Michael Douglas in the movie Wall Street with his then state-of-the-art cell phone. So for this audience, I also really want to get across the point that clinical genetics is increasingly relevant for the adult population and is applicable and important for what we think of as common diseases. So a few examples. Angelina Jolie, in genetics, we talk about the Angelina effect because she has really spurred interest in hereditary breast cancer testing with her own disclosures of her own hereditary risk and the choices that she's made. Hank Gathers was a very talented basketball player who unfortunately suffered sudden cardiac death from hypertrophic cardiomyopathy, a genetic condition with a prevalence of 1 in 500. And over on the right is, you may not know him by name, Jay Monahan, but I'm sure you know his wife, Katie Couric. And Mr. Monahan was a New York lawyer who unfortunately died at a young age from colon cancer, which again was likely from a hereditary cause. So in 1 hour, I cannot teach you to be a geneticist, but I can teach you when to think about genetics. And so this is an eponym family genes for red flags to think about genetic conditions. So first of all, if the patient tells you that they have a family history of several family members who have the same thing, then think genetics. Second, if there are 2 or more congenital anomalies, so these are things like cleft palate or VSD, then think about genetics. Extreme presentations of common conditions. So we say that 5 to 10% of breast cancer is strongly hereditary. And again, that means 95% is not strongly hereditary. But the ones that we see in the genetic clinic tend to have unusual presentations, such as breast cancer at very young ages, or bilateral breast cancer, or cancer that is in paired organs on both sides, like bilateral renal cancer. Genetics is very important for neurological diseases, particularly neurodevelopmental delay, and a young adult who has Alzheimer's disease, say before the age of 60, or other young onset neurodegenerative diseases such as inherited ataxias. Exceptional pathology, acoustic neuroma or pheochromocytoma, and very abnormal lab values such as sky-high cholesterol. So basically, I like to say that in genetics, we see the most interesting patients from every other aspect of medicine. Now, I know that, so these are my fellows, and so this is a photo of last year's fellows and current fellows. And I want to emphasize that Joe here trained in internal medicine, and many of you here know Andrew Dervin, who actually graduated from the internal medicine program here before doing medical genetics training with us. And on the right are the current genetics fellows with Dr. Jim Lupsky, who was the 2016 Metulsky lecturer. Now, I only have a handful of fellows that I train, and I know Ken Steinberg has 180 fellows. So you cannot all do an elective in genetics with me, and you cannot all come to my clinic. But I thought I would bring my clinic to you. So this is just a week in the adult medical genetics clinic, and specifically the patients that I have seen recently in 1 week. And so if we look at this list of diagnoses, you can see that what they have in common is that these are all potentially genetic conditions. And you can see that there is a very wide range from common conditions like epilepsy or intellectual disability, what at least in genetics we think of being fairly bread and butter genetic conditions like neurofibromatosis type 1. We see people for indications of family history where they themselves do not have it but ask whether they're at risk. And we also do see some of these really, really rare syndromes like Malin syndrome, which probably no one here has heard of, but it's an overgrowth syndrome. Now, if I reorganize those diagnoses into by specialty, then you can see that in 1 week, I have seen patients referred from cardiology, oncology, nephrology, and dermatology. So four of the other 13 other divisions in the Department of Medicine. And I'd say over the course of a year, we have referrals from nearly every division. Also, we have referrals from ophthalmology and neurology. So again, our organ of interest is, I consider to be the genome, and what we do in the genetics clinic is we evaluate how genetic variation affects every other organ system and causes disease. So I'm going to start out with a case of just a couple who came to my clinic that week because they were at risk for hereditary cardiomyopathy. Okay. So the story of this patient actually starts last year in September when I was asked to do an inpatient consult on the cardiology service. So this is an 18-year-old woman who was, she started to feel fatigued as a high school senior. She gained weight the summer before leaving for college. And then she arrived at her East Coast college in mid-August and started to have a cough and dyspnea going upstairs. Then she had the sudden onset of nausea and vomiting and a headache while watching rugby, and she had joined a rugby team there. So she went to the emergency department. They diagnosed her with migraine and sent her home. She progressed to have visual changes, unsteadiness of her gait, returned to clinic, and was admitted to the ICU in New York. She was found to be in heart failure with an ejection fraction of 10 to 20%. She had a thrombus in the left ventricle and had suffered a right stroke in the posterior cerebral artery territory. She was actually from Washington State, so her family asked her to be transferred back here to UW Medical Center, where I was asked to see her. So in medical genetics, the family history is front and center, and to us, the family history is like the stethoscope to the cardiologist. Okay. So this is the family history then that I took. Okay. So I'm going to spend a little bit of time on this, so this is the patient indicated by the arrow, and so she presented with severe cardiomyopathy and stroke. On her paternal side, there's unusual cardiac history on both sides. Her uncle was supposedly had heart failure as a child and missed a month of school for this, but then recovered. What is that? This cousin over here is actually being evaluated, in the process of being evaluated at Seattle Children's Hospital for mitochondrial myopathy. Specifically, she's had echoes that have been normal, I'm told. This uncle has atrial fibrillation, and again, he's rather young to have atrial fibrillation, in his 30s or 40s. The grandfather had scarlet fever and supposedly had cardiac complications from that. This great uncle died in his 30s from supposedly he had a heart attack induced by medications which were given to him while he was in a mental hospital. And then this, great-grandfather here, again, very strange story. He went from Chicago to Washington, D.C., had a cardiac event there at 35, was hospitalized for 6 months, and then came home and recovered. So again, not specific diagnoses, but rather unusual family history. So back to this patient, her EKG here showed sinus rhythm, left anterior fascicular block, and precordial T-wave inversions. On cardiac MRI, she had increased size of both the right and she had biventricular enlargement and severely reduced ejection fraction of both the right and left ventricle. She had late gadolinium enhancement, and this was thought to be consistent with myocarditis. Viral studies were normal, sed rate was normal. The question was, did she have viral myocarditis? And I was consulted because of the family history of the cousin, okay? And so I saw her and I considered genetic causes of cardiomyopathy potentially, including disorders of fatty acid oxidation, lysosomal storage diseases. Because this came from her, if it was mitochondrial, it would be through her father. So this could not be a mitochondrial encoded condition, but it could be a nuclear encoded mitochondrial disease, I thought. Given the lack specifically of toxic infectious causes, her rather unusual family history, and extremely young age at onset, I did think that this was genetic, and so requested genetic testing for her. This took 3 months to accomplish for reasons I won't get into here, but the results were diagnostic. We found an answer. She has a likely pathogenic variant in the gene TTN, which encodes titin. Now, she also, in this evaluation of 75 genes, had reported variants in 2 other genes, which I'll get back to in a minute, but those were both considered to be variants of uncertain significance. So these 2 results are not diagnostic, but this one is. Okay, so basically, we know now that mutations in the titin gene are the most common cause of familial dilated cardiomyopathy, accounting for 25% of cases, and cause about 18% of sporadic cardiomyopathy. So this diagram here shows that the thick filament, the thin filament of the sarcomere, and then the orange is actually titin. And then below are 3 isoforms of titin, and then these vertical lines basically show the location of different mutations in this gene causing cardiomyopathy. So one point that I want to make is that genetic test results are rarely positive or negative, so they're not straightforward. Instead, the results of any genetic test can be pathogenic, or what people call a mutation, benign, or uncertain significance. In addition, labs have come to add 2 additional categories, so a total of 5. They've classified things as likely pathogenic if they're 90% certain it causes disease, or likely benign, where there's some evidence it's benign, but not enough to be totally certain. So again, to get back to this patient, she had 2 of these variants of uncertain significance. So what did I do with these? So basically, I looked at them very carefully, and I looked in large databases like the Exome Aggregation Consortium and ClinVar, and I will just tell you that I did not consider the JUP gene to be related to her pathology because it causes a different cardiac phenotype, but I looked at this one very hard. TCAP encodes titin cap, which interacts with titin. And then I contacted a colleague at clinical lab at Harvard Partners because they had reported it. And when I talked to the director there, she told me that this same variant had been found in a single individual who also had a titin pathogenic variant and presented with dilated cardiomyopathy at an extremely young age. We know that Although there's a range for Titin, patients typically present later in life with dilated cardiomyopathy in their 40s. So because of that, I elected to evaluate for the TCAP VUS, or I gave the family the option to be tested for this as well as Titin. So her parents were the two family members who came to my clinic that day, because now we want to test who else in the family is at risk to have this, right? So she has two healthy sisters. And so again, we started by testing the parents, because if this is new in her, then there's minimal risk to any other family member. And so the answer is actually that she inherited the Titin variant from her father and the TCAP variant from her mother. Okay. So next I have recommended that both parents actually undergo screening echocardiograms. We know that there's incomplete penetrance for Titin mutations. So they could be perfectly fine and never manifest cardiomyopathy. But again, we're going to start tracking this through the family. And we did this so we sent this in March, and I just got the results back last week. And so again, remember, I started with this family in September, and the saga continues. So I do want you to know that genetics is not like CSI, where we can solve everything in an hour or less. Oftentimes it's like this, and we actually have to go through many iterations and meet many family members to actually solve our cases. Okay. So in the past, most genetic testing was on the order of single gene testing. So in other words, we saw a patient, we thought that they had tuberous sclerosis, and we would send two genes that are known to cause tuberous sclerosis. And the cost of this was between $1,000 and $2,000. And so the art of genetics was really in that very precise recognition of unusual phenotypes and being able to hone in on what the patient had. So a great deal of clinical acumen is required. Nowadays, we have the ability to test gene panels of maybe 6, 20, 50, or 100 genes that can cause a phenotype which is very heterogeneous and has many potential causes, and the cost is like $2,000 to $5,000. Again, just to give you a 30,000-foot view of the state of genetic testing in one area, this is an overview of currently available clinical cardiac genetic testing as it applies to conditions like hypertrophic cardiomyopathy, dilated cardiomyopathy, as well as arrhythmogenic right ventricular dysplasia, long QT syndrome, Brugada syndrome, and so on. So we have a whole array of clinical genetic testing that we can currently deploy for diagnostic purposes now in the clinical setting. Obviously, this is a complex area, and the informed consent is similarly complex. So this is a screenshot of cardiology genetic testing informed consent document. And there are 14 points to go over with the patient, okay? So genetic testing is not just a blood test. We do need to carefully inform the patient about the risks, benefits, and implications for them as well as their family members before doing any genetic testing. And that is why the American Heart Association has made a formal recommendation that cardiovascular genetics is best done with the involvement at centers who have expertise in cardiovascular genetics, who actually understand when and how to order genetic testing, how to interpret the results, and incorporate them into the management of the patients. And that cardiovascular genetics centers are in the best position to do this and provide pre- and post-test counseling. So do we have that here? Yes, we do. I'm really glad to say. So we have comprehensive adult cardiovascular genetics services here. The cardiomyopathy program is led by Dr. David Owens, and Emily Malouf and I go to that clinic twice per month. We also see patients with inherited cardiogenetic disorders with Dr. Patton and Jordan Prutkin. And Peter Byers sees patients in a connective tissue cardiovascular genetics program for aortopathies and Marfan syndrome-related disorders. And then we share patients also with the adult congenital heart disease program. And again, many of those patients have genetic causes for their congenital heart disease. So I'm going to move on to another case that illustrates some additional points. So this is a 25-year-old woman who went to see her primary care provider literally for a wart on her finger. But as she was leaving, she said, by the way, I'm worried about my family history of breast cancer. And so the PCP sent her to our clinic. And when I took the family history, I was worried about her family history of breast cancer also. So this is her, and she's a healthy 25-year-old woman. Her grandmother died of breast cancer at 35. Her great aunt died of breast cancer at 37. Her aunt was diagnosed with breast cancer at 33. I'm sorry, I should have drawn the slash through here to indicate that she was deceased. And her mother really tragically underwent preventative surgery to prevent breast cancer and then developed ovarian cancer and died from that. So this is a situation where this is clearly, there's concern for hereditary breast and ovarian cancer in this family. The problem is that none of the affected people are alive to test. And whenever possible, it's an important principle to test the person in the family you think has the genetic condition and not someone who does not have it. Okay. But no one was available. So in this situation, it is indicated to offer her genetic testing with appropriate pre and post-test counseling. So her results were positive for a pathogenic variant in a BRCA gene, and this immediately changes her medical management. So she is now eligible for high-risk screening, and she has options for risk reduction. So prophylactic risk-reducing mastectomy reduces this woman's risk of breast cancer by more than 90%. And we also know now that prophylactic bilateral salpingo oophorectomy after having children can reduce her risk of ovarian cancer by more than 95%. So there's extremely effective interventions that can come directly from genetic testing and evaluation. And this makes a huge difference in her life to change the course of what has previously happened in her family. I'm going to contrast this with another patient, also with a family history of cancer, this time a 40-year-old woman who went to her PCP and said, my mother was just diagnosed with ovarian cancer. I want that genetic test for ovarian cancer. So her PCP orders genetic testing. What does he order? BRCA1 and 2, of course. But which one? If you actually look at a requisition from one of the genetics testing labs, there's 3-site testing, there is sequencing, there's deletion duplication, there's comprehensive testing, and we're just talking about BRCA1 and 2. So which one should he order? Well, if he orders the comprehensive one, then it should be fine, right? Comprehensive means comprehensive. The results were negative, however, and her insurance declined to cover this $4,000 genetic test, which reminds me of the saying, if you think it's expensive to hire a professional, wait until you hire an amateur. Okay. So the mother was then referred to our clinic, and we did what we do, which is we took a screening family history over the phone. We recognized that we needed to obtain medical records for her, as well as for the mother, as well as for this original woman's uncle and grandfather. So we were actually able to get records which showed that her mother had not ovarian cancer, but uterine cancer, okay? And that is very important because the genetics are totally different. And so now, based on records, this family meets Amsterdam 2 criteria for Lynch syndrome. And so we sent the appropriate testing on the mother and showed that she has a pathogenic variant in MLH1 causing Lynch syndrome and confirming a diagnosis of Lynch syndrome in the family. So no wonder this woman's BRCA testing was negative. That's not the appropriate test for her. So Lynch syndrome is a hereditary cancer condition. It's sometimes called hereditary non-polyposis colon cancer. Compared to the population risk of cancers over here, in Lynch syndrome, these are the elevated risks for the associated cancers. And I like this graphic, which also shows that compared with the population risk, the risk of colon cancer from Lynch syndrome approaches 80%, and then for familial adenomatous polyposis approaches 100%. And so what we want to do with genetic testing is we want to evaluate people here before they have colon cancer or another Lynch syndrome associated cancer and prevent their cancer. So this is an example of precision medicine. The next case is a 17-year-old girl who's referred from our maternal fetal medicine colleagues, who was a young lady who was currently pregnant. And she had flank pain and blood in her urine, so she went to the emergency department. They confirmed she had hematuria and proteinuria. She had a renal ultrasound, which showed multiple bilateral renal cysts up to 4.5 centimeters on the right and 2.5 centimeters on the left. And there are her kidney sizes. On abdominal MRI, she had an enormous number of cysts, over 50 cysts, most of them being less than a centimeter, but no cysts were present in the liver or pancreas. So her family history was notable for hypertension. Both of her parents were living. Neither of them had renal disease. Neither of them had a history of aneurysms. Neither had had ultrasounds at that point. And her background is Mexican, Quinault, and Lummi, or Native American. So our working diagnosis for her was polycystic kidney disease then, based on her evaluation so far. So we obtained pre-authorization from her insurance for a mini panel on demand at the Center for Precision Diagnostics and proceeded with sequencing of PKD1, PKD2, PKHD1, and GANAB. So those cause dominant polycystic kidney disease, recessive polycystic kidney disease, and a polycystic kidney and liver disease. And the results were negative. Okay, so this is one of those that kind of left us scratching our heads a little bit, because surely she must have polycystic kidney disease, and surely it must be genetic given her young age at onset. But there are a number of features about her case which are unusual if you know polycystic kidney disease. First of all, she is so to have so many cysts, right? And 95% of patients with the most common forms of autosomal dominant polycystic kidney disease have an affected parent, right? So again, this is an unusual case. So I also want to just put in, just mention the Center for Precision Diagnostics for those of you who may not be familiar with it. So the Center for Precision Diagnostics was founded here at the University of Washington after Dean Ramsey recommended establishing a clinical center for precision medicine. So clinical services were launched in 2015, and they are offering next generation sequencing panels, both on a clinical basis as well as a research basis for a growing number of hereditary conditions. And here is Peter Byers, the director of the center, along with Michael Dorschner, another director at the center. So back to this case. What went wrong? Is it the wrong diagnosis? Is it the wrong gene? Is it the wrong method of identifying the gene? Or could it be lab error? And again, any of these things are possible, so we really have to go back to the drawing board. Anybody here not a geneticist want to guess? Okay. All right, so what we did then was we went back to the drawing board. Again, really thought about the phenotype, really seems like she has polycystic kidney disease, whether it's dominant or recessive, or de novo, we don't know. But we also have to think about the scope of human genetic variation. And so this is what we think about in genetics. So at the whole chromosome level, the addition of a whole extra or missing chromosome causes trisomy or monosomy. In the middle here, between 1,000 base pairs and 1,000,000 base pairs, are what we call copy number variants. And over here are single nucleotide variations, like substituting A for a C or a T for a G. And there are also many different, there's not a genetic test, there are many different genetic tests that, again, are targeted to the type of genetic variation we are concerned about. So, Emily Malouf, a stellar genetic counselor in our group, requested another pre-authorization from insurance for additional testing, and she got it approved. So, we requested deletion duplication testing, and this showed a multi-exon deletion of exons 31 to 33. So, again, this is a type of genetic variant that is not detectable by the test that she had. So, you might ask, well, why didn't you just send it at the beginning? The reason is because fewer than 7% of pathogenic variants in PKD1 are this type, deletions or duplications. So the testing we sent was an excellent test. It should have identified the mutation in 93% of patients if it was in this gene. But for her, it was the right gene, wrong test. And so the follow-up now is that she does have dominant polycystic kidney disease. There's a 50% risk to her child. And again, when we met her, she was 33 weeks pregnant. We don't know at this point if it was a new mutation that started with her or if it was inherited from a parent. So again, the saga continues with this family like many of our other families. Okay. I want to talk for a few minutes about massively parallel sequencing or next generation sequencing and how that is transforming our field and some of the both challenges that it brings as well as some of the opportunities that it brings. So massively parallel sequencing basically enables us currently to sequence all 20,000 genes in our genome within a period of about a week. And so those of you who followed the Human Genome Project may recall that it took a decade to sequence one person's genome. So this is truly astonishing, and I heard a genetic speaker once who said that this is the equivalent of being able to buy a Mercedes for like 50 cents, okay, in terms of the dropping cost and the increase in data. The way that I like to think of it is that in the past in genetics, we focused on single gene testing. So it was like looking through a keyhole or really having that pinpoint clinical acumen to diagnose a condition. Nowadays, we have the ability, again, to very quickly sequence most of our 20,000 genes or even to do whole genome sequencing of all 3 billion of our base pairs. And so now we have a panoramic view of anyone's genome. Okay. And I want to show you a very quick example of the power of this technology. So this is an 18-year-old woman who I saw in the genetics clinic, and she had a lifelong movement disorder which began in infancy. So she had chorea and dystonia, which was prominent at rest and alleviated by physical activity. So she had nearly constant abnormal movements of her limbs, which affected her face, and mild dysarthria. However, she had weeks of total remission where she had no abnormal movements. And this young woman had been on a diagnostic odyssey most of her life and had been seen at neurology clinics and movement disorder clinics from Vancouver to Texas. So I think we were her 12th or 13th clinic. So when I saw her and went over her records, I knew what she did not have. And I can give you a long list of differential diagnosis of things that cause chorea and dystonia, but I won't for the sake of time. But I knew that it was genetic in her because this was developmental, it was persistent, she had no family history, but I strongly suspect it was genetic, and I sent exome sequencing on her. So this is just a video of her abnormal movements.
Okay.
So the exome sequencing was, of course, diagnostic in her, and it identified a single base pair substitution in a gene called adenylate cyclase 5. And so this is actually the first example of a movement disorder caused by mutations in adenylate cyclase, and it was described only in 2012. So it's not something that, it's a very obscure disorder, but this basically found the cause of her movement disorder after, again, 18 years. So it's really like finding a needle not in a haystack, but in a stack of needles, right? Finding that one genetic variant that caused this for her. And there were no variants of uncertain significance. What was even more astonishing to me was that this disorder actually is that mutations in this gene also cause familial dyskinesia, facial myokymia, and an essential benign or hereditary chorea. This is a different mutation in the same gene. And these conditions were actually reported here by Tom Bird. Okay. So Dr. Bird in the Department of Neurology and the Division of Medical Genetics actually described what at the time he called essential benign chorea. And then later, Tom decided this was actually a poor name for it because it does affect the families significantly. But he called it that to distinguish it from a neurodegenerative fatal chorea like Huntington's chorea. And for 40 years, people thought this was the only family that had this, okay, until the causative gene, ADCY5 mutations, was discovered in 2012. And so that basically enabled people to recognize that many patients had this disorder, okay. And so this actually has really transformed the field of movement disorders in order to be able to identify how many patients have what was thought to be an extraordinarily rare syndrome. So I like to call this Bird-Raskin syndrome, actually, after Tom Bird and Wendy Raskin here, or ADCY5 related dyskinesia is another name for it, and it unites what were thought to be actually 3 or more separate conditions, which are now known all to be caused by ADCY5 mutations. Okay. So now that we have access to all of this data, how many variants are in the human genome? So all of us have about 3 million variants that differ from the reference sequence, but all of us are 99.999% the same at any place in the genome. So this brings up an important medical question, which is if you have access to all of your genes, how many people will have a medically actionable incidental finding? So in other words, who out there will have a BRCA variant or a Lynch syndrome variant that they don't know about, but which could be important to their health for them and their family? So we now have access to big data and big tools to start to answer these questions. I want to just briefly mention the Clinical Sequencing Exploratory Research Consortium, which is led by Gail Jarvik here at the University of Washington, and is a consortium of centers which are working to understand how to apply genome sequencing and exome sequencing to clinical problems. So one of the questions that the group asked was, how common are actionable incidental variants in the genome? In order to answer this question, we evaluated exomes from 1,000 participants in an exome sequencing project. And Gail convened a return of results committee of 24 individuals with varying expertise. And we came up with a juried list of 114 genes that we considered to be medically actionable. So basically, after very carefully vetting these variants and going to the primary literature, then it was found that 1 to 3% of participants had pathogenic or likely pathogenic medically actionable incidental variants. And also importantly, out of this work, it became evident that 90% of the variants that are reported as disease-causing in the medical literature are not. Okay. And the reason for that is because we use very strict classification criteria of when to call something pathogenic. So again, we're talking about a healthy person. They don't have the disease, but we're saying we're going to give them a disease based on their genetic finding. So we had a very high bar, strict threshold to say that someone had a pathogenic variant. And so these are the criteria that we used. It either had to be a disruptive variant, which would be predicted to severely interfere with the protein function, or show segregation, or have independent confirmation in multiple affected people. Okay, I'm going to skip this. And we know that interpretation of a variant is clinically important, and the stakes are high. If you overcall a variant or have a false positive, you could subject a patient to unnecessary treatment like an ICD or expensive monitoring. A false negative, on the other hand, and underestimating someone's risk could result in cancer or sudden cardiac death. And of course, because we're talking genetics, this problem is multiplied by all of their family members. This is currently a problem even for professional geneticists. So in this slide, here are 6 variants across the top, and these are 6 labs across the vertical across here, 1 through 6, and basically they were given the same variant, and they say, you classify it according to your criteria. And each lab in the past has had their own criteria. And you can see that for some variants, like this one, they all agreed it was pathogenic. But for many, there's actually a spread. And if you gave the same variant or the same DNA sample to 3 different labs, one would call it pathogenic, one would call it uncertain, one might call it benign. So this is clearly a problem for clinical genetics. And so the American College of Medical Genetics is working on solving this problem. By the way, out of this project also it came out that many variants are, again, overcalled as pathogenic. Oops. So another example that I want to give is hereditary hemochromatosis. This is considered to be the most common genetic condition in persons of European ancestry with a prevalence of 1 in 300. And it is considered, if you look at your medicine textbooks, a classic triad of cirrhosis and diabetes and bronzing of the skin, and is caused by iron overload. So we know, though, that it's a genetic condition, and so people have the mutation at birth. They have a period of being asymptomatic, and then typically have deposition of iron and organ damage in midlife, so between the 40s and 60s. But how many people actually are born with the mutation but never develop any of the symptoms? So this is basically the concept of penetrance in genetics. If 100 people who have the genotype all develop hemochromatosis, after a certain age, the penetrance is 100%. If only 10 of them develop clinical end organ damage from hemochromatosis, the penetrance is 10%. So now, in the past, we only really identified people if they showed up with bronze, diabetes, or cirrhosis, and you thought they had hemochromatosis, and then you tested them. But nowadays, with big data, this is a project from the eMERGE network, and the first author here is actually one of our fellows, Carlos Gallego. They looked at the medical records of over 500 adult patients who had been genotyped, and they actually were able to determine that the penetrance of hemochromatosis is extremely low. So for this genotype, it was only 14% had clinical hemochromatosis according to review of their medical records or significant liver disease, and 2.3% for this compound heterozygous genotype. Okay. So from big data, again, incidental genetic findings are a problem. The American College of Medical Genetics has come up with a a work in progress list of 59 genes that should be looked for and reported in any patient's clinical exome or genome. And I just want to point out that most of these disorders are adult onset disorders, okay? So internists really need to be aware of these kind of findings. And this is actually the attempt of the ACMG to unify variant classification. And so I spend a lot of time with this table, actually, and classifying or reclassifying variants myself. So as an internist, should you order genetic testing? I think before you answer that question, we should look at the data and ask, are physicians trained to provide medical genetic services? So in a recent survey of medical genetics course directors, only 20% taught genetics in the clinical years. So not the preclinical years, but the clinical years. The total time spent in genetics education in medical school is 36 hours on average. This is the paper that was published in the Journal of Medical Genetics, a survey of that was sent to 1,200 physicians from the AMA master file. So all of the individuals surveyed were licensed physicians who were currently practicing, and their primary activity was patient care. It didn't matter if they belonged to the AMA has their name anyway. And so they basically asked a few questions about their knowledge of breast, ovarian, and colorectal cancer genetics. And so this is the first question. Your patient's paternal aunt or grandmother has a BRCA1 gene mutation. Could your patient also carry this mutation? So these are the choices, so think about your own answer for a second. Okay. So again, you have a patient, so their father's sister or mother has a BRCA mutation. Can your patient have a mutation? Yes, no, or not sure. Okay. So these are the results. This is the correct answer, yes, okay. And as you can see, internists, only about a third got it right. Gastroenterologists, only about a quarter got it right. OBGYNs were a little better, half. Oncologists were the best, but still a third did not get it correct. General surgeons did better than internists. Okay. Okay. And interestingly, there was no difference when they broke this down by age. So physicians over 60, 41 to 59, and less than 40 had the same correct response rate. But half of them had actually ordered breast ovarian cancer genetic testing in the past year. Kind of scary, right? They didn't realize that this can be inherited from the father's side as well as the mother's side, but they're still ordering testing. And if you don't believe this happens, I had a patient tell me this just like a couple weeks ago in clinic, that her primary care provider had told her that you can't inherit it from your father. This is another question. What percent of patients with a gene for Lynch syndrome or HMPCC will go on to develop colorectal cancer? Less than 50%, greater than 50%, or not sure? Again, take a few seconds to think about your own answer. And so again, pretty dismal results here. And if you have paid attention in this lecture, you actually knew the answer because I showed it to you before, right? So just from attending this lecture, you would have done better than most of the people in this survey. So it is an unfortunate or inconvenient truth that whether it is surveying the knowledge of OBGYN residents about breast cancer or medical students about neurogenetics or cardiologists and genetic testing, most physicians do not understand the application of genetics to their practice of medicine. And this was another paper that was published in American Journal of Medical Genetics, which concluded that a third of genetic tests were ordered incorrectly by non-genetics providers, and that when the testing was reviewed in the lab by genetics professionals, genetic counselors, that review saved the ordering institutions $48,000 per month. So we're all concerned about efficiency and cost effectiveness, and so basically the most cost effective thing that you can do is work with a geneticist. Okay, so again, to answer the question, should you order genetic testing? I think you need to ask yourself. I'm not going to answer that for you, but you need to ask yourself, do you know about genetics, including variants? Do you participate in continuing medical education around genetics? Are you willing to obtain those critical records on family members to confirm diagnoses? Do you understand insurance coverage for genetic testing? Are you able to provide pre- and post-test genetic counseling? And are you seeing enough to make this all worth your while? Probably. So for many people, I think the answer will be no, but then what are you supposed to do? So this is what I suggest you do. First of all, learn more about genetics. Second of all, make friends with a geneticist. And third, become a medical geneticist. And remember, I said this talk was for the residents. So we happen to have a ACGME certified residency in medical genetics and genomics right here. And again, these are the pathways for a medical student or a resident to become a medical geneticist. And again, we see patients over the whole lifespan. It's not only adults. It's not only children. And according to current data from the ABMGG, only 124 internists have ever been board certified in medical genetics. We need more. Okay. I am running short on time, so I'm going to just fly through this last part on the Precision Medicine Initiative, which is basically that idea that in the past, we have given the same medication to a group of patients based on diagnosis, but their responses are quite varied. In evidence-based medicine, we actually use genetic diagnosis to sort who should and who should not receive a medication. This has led to President Obama's Precision Medicine Initiative, now rebranded the All of Us Research Program, which basically takes advantage of the current greater understanding of genes and access to big data, and as well as patient engagement in research. So our traditional model of medicine has been something like this, where first the patient becomes sick. That's our starting point. Then we do a history, an exam, a differential, select a test, make a diagnosis, and treat them. Does this sound familiar? Yes. So, but in precision medicine, we basically can rearrange the pieces and put genetic evaluation front and center at the beginning. Okay. Again, with the idea of preventing disease in the first place. Okay. I think a threat to precision medicine and to genomics, however, is direct-to-consumer genetic testing. places like 23andMe. I will tell you that I talked to a lot of people about this. People do not understand what they are getting with 23andMe testing. They think they are getting whole genome sequencing or whole exome sequencing. They are not. Okay. I've seen a lot of patients come in with misunderstanding about what they have had and what they are at risk for. And this is still a problem because as of last week, the FDA has said that 23andMe can now actually sell genetic risk tests to consumers for 10 conditions. Okay. In the end, though, I think that medical genetics and genomics always, like all of medicine, comes back to the doctor and the individual patient. So we're currently at a stage when we have all this great information, all this great technology, but we still need to bring it back to the clinic and the individual patient. I want to thank my colleagues in the Division of Medical Genetics here, again, including Gail, Dr. Matulski, and Dr. Stan, the 3 division heads ever since 1957. I also want to just mention Dr. Mary Claire King will be giving the Distinguished Scientist Lecture a week from today. Please go see that if you have the opportunity. And again, I want to thank all my colleagues in the genetics clinic.